all women in India are at risk of gestational diabetes. So, but if they have got a higher body mass index, that increases the risk. If they have got anybody with diabetes in their family, that again increases their risk. If they have got previous glucose intolerance, that increases their risk. And obviously, if they have had a previous pregnancy and the baby in the previous pregnancy was more than 4 kilograms, that also increases the risk of gestational diabetes in the current pregnancy. So when do you test these women for the gestational diabetes? And what test do you do? The standard recommended test is a 75-gram oral glucose tolerance test, which is usually done between 24 to 28 weeks of pregnancy. So the patient comes fasted, overnight fast of 8 to 12 hours, and then they are given a 75 gram of glucose to drink. But prior to that, you get a fasting venous test, plasma glucose, and you can do the blood venous plasma glucose test at 1 hour after the glucose load and at 2 hours after the glucose load. And based on the results, you can see. So in the HAPO study, what they did is they looked at different glucose categories. Those who had very low blood glucose, that is less than 90, between 90 to 100, 100 to 110 milligrams per deciliter. So fasting blood sugars of various levels, they categorized that into different category 1 to category 7, and then they categorized the blood sugars again 1 hour postprandial and 2 hours postprandial, and they looked at the outcomes. With each rising category of blood sugar, the risk of increasing birth weight in the baby, risk of need to do primary cesarean section, and the risk of neonatal problem such as hypoglycemia, and also the cord serum C-peptide. All of this increased with each category of blood sugars. So it's a linear relationship which is going up. So when do you say that you need to intervene? So do we intervene here? Do we intervene here? Do we intervene here? And because once you start treating, that itself results in a bit of complications, because you need to introduce medications, and the patients will have to come to your clinics more frequently. That's an inconvenience for them. And are we really going to make a difference? If you give a tablet of metformin here or insulin here, is that going to make a difference to the baby and the mother? So there are several questions to be answered subsequently once you have made a diagnosis. So as a consensus, the IADPSG, WHO and IDF have all come to a conclusion that to look at the risk, if the risk is 1.75 times the accepted baseline, then that is a high risk. So when the odds ratio of any complication appearing is 1.7, it's not times, it's the odds ratio of 1.75 of a particular complication appearing, that is the cutoff point. So based on that, they decided the cutoff points for blood glucose for diagnosis of diabetes, gestational diabetes, which is 5.1, that means 90 milligrams per deciliter, which is lower than the cutoff for somebody who is not not pregnant. So sorry about this. Go back to the previous slide. Can you do it now? Yeah. So here you can see the fasting plasma glucose of 5.1, which is 92 milligrams per deciliter, which is much lower than what you would do in a non-pregnant woman. And again, 1 hour venous plasma glucose, 10 is considered as diabetes. 2 hours, 8.5, which is 153. Whereas in the non-pregnant state, it is about 11.1, which is nearly 200. So you can see that the cutoff points have been dragged downwards during pregnancy, because we can't accept any risk to the baby. So we try to cut down the risk, so you bring down the cutoff points. But of course, if the fasting venous plasma glucose is more than 7 or more than 126, you can diagnose overt diabetes, which means the complications are higher. Now in gestational diabetes, the blood glucose starts rising about 24 weeks or 22 weeks at that period of conception, pregnancy, the blood sugar starts rising. So the first trimester, the blood sugars are all right. So the first trimester is the most important for the baby in terms of organogenesis, the heart, the formation of the heart, formation of the kidneys, all these organs are formed in the first trimester of the pregnancy. So during that first trimester, in gestational diabetes, the sugars are fine. But in those women who had diabetes before pregnancy, even the first trimester is at risk. So you need to act right even before they actually fall pregnant. So for these patients, you need to start managing them pre-conception. So in UK we have pre-conception clinics. We call them to our clinics even when they start saying that I want to have a baby. We call them to the clinic and start helping them improve their blood sugars. So the ideal blood sugar target for them should be less than 6% or less than 6 if it is safe. The problem is safety. The more intense you manage, the higher the risk of hypoglycemia, higher the risk of complications for the patient. So you need to get that balance right. How much to intervene, how to intervene. Okay? So does it help intervening? Does it help the patient at all if you start managing that diabetes in pregnancy more intensely? And the answer from the studies after the introduction of the HAPO guidelines, IDPHC guidelines was yes. Macrosomia, which is the baby of larger size, decreased. Relative risk of macrosomia once you start introducing this is only 0.4. If the standard risk is 1, here it's 0.4. Large for gestation is 0.5. Preeclampsia is 0.6. And cesarean section reduced by up to 10%. So there is benefit from the introduction of these guidelines. But there is a cost to it. There is a problem, there is an additional inconvenience for the patient and their families. So I'll now pick out a few papers which were discussed in the EASD recently and take a few snippets from that. So the first one is okay. No, go to the next one. Okay, so the first one asks you a question: can you prevent gestational diabetes? In the first talk I had done earlier in the session was about lifestyle measures and whether you can reduce the risk of progression into diabetes from pre-diabetes. The same question here, this is for a pregnant woman. Can you reduce the risk of gestational diabetes? And the answer generally is yes, but it's not that easy. Okay, so why do you need to reduce the risk? Because of these complications short term. If you don't reduce that risk, what will happen is with the increased blood sugar in the woman, all that glucose goes to the baby intrauterine, and it's just like if you start eating sweets and chocolates from today onwards, having half a kilogram of sweets every day. In a few months' time, you'll have put on 10 kilograms. In the same way, for the fetus, the extra blood glucose which crosses the placenta into the fetus results in increasing body weight for the fetus. So shoulders get bigger, tummy gets bigger, and that results in difficulty in delivery. So during the delivery, there can be shoulder dystocia, injury to the nerves there, or you may not be able to deliver the baby at all and you have to go into cesarean section. So there are problems for the baby. Long term, because the baby has been exposed to high sugar levels intrauterine and has put on weight during the pregnancy, there is metabolic memory in the baby. So long term, there is increased risk of childhood obesity, increased glucose intolerance, and like the mother, the baby also can progress on later on in life, if not careful, to develop diabetes. So all these complications are higher. So there is a need for intervention and prevent gestational diabetes in the first place, if at all it's possible. So how do you prevent? By targeting the risk factors. So what are the risk factors here? Some of these are well documented and easily understood. If the mother is obese, higher risk for gestational diabetes. Like the usual diabetes, advancing maternal age. These days women go to work, they are more career oriented, so the family is completed much later. So advancing maternal age is a risk factor for diabetes. Just like any age progression is a risk for diabetes, even for gestational diabetes is a risk factor. And being an Indian is obviously a risk factor for gestational diabetes. Did her mother have diabetes? Or her father, anybody in the family having diabetes, that indicates that they've got a predisposition genetically to develop poor glycemic control. And previous gestational diabetes, and previous large baby, or conditions like polycystic ovary syndrome. And the polycystic ovary syndrome is a condition which develops in patients who have got insulin resistance. So having this polycystic ovary syndrome indicates that the patient has got insulin resistance. And during pregnancy, the maternal placental hormones, which are all steroid hormones, they make the body much more insulin resistant. So I have seen patients where I have had to multiply their insulin dose 5 times, 6 times, and there are patients who are on hundreds of units of insulin 3 times a day, 4 times a day, and despite that the control is very poor. And that is simply because of insulin resistance. And we also know that cigarette smoking and using some food additives, they are all known to increase the risk of gestational diabetes. Okay, so risk factors, genetic, there's not much of data on how to intervene genetically. We can't do that, at least not at the moment. Maybe genetic engineering in the future might be able to help do something, but not right now. Environmental factors. Now there are perfluorooctanoic acid. This is used as an additive in the microwave popcorn. If you go to the supermarkets, you can get packets which you can put in the microwave and you get popcorn. So this particular product is known to increase the risk of gestational diabetes. but I don't think it is used that much in India. Okay. So what interventions? Again, just like the lifestyle measures, diet and exercise during the planning phase for pregnancy. So patients with type 1 and type 2 diabetes and anybody at risk should plan properly if they want to become pregnant and want to have a baby. Plan beforehand. Make sure that your body mass index is acceptable. Make sure that blood sugars are in the good range before pregnancy. Therefore, in my clinic, I advise these patients to use contraception until their blood sugar is excellently controlled. So what are the ways that they can do it? Increasing physical activity, good health and healthy life patterns, and Mediterranean diet, which means diet rich in salads, and a diet which is rich in nuts and fruits. This decreases the risk of diabetes. A diet which is rich in fiber, grain fiber, fruits, and vegetable protein. These are all factors which can help reduce the risk of gestational diabetes. Whereas meat protein, animal protein increases the risk, processed food increases the risk, and of course sugar sweetened beverages. Even fruit juices are not recommended. You can use whole fruit. Whole fruit is more better, more advantageous than drinking the same thing. If you squeeze the orange and take the orange juice, discarding all the fiber content, that is harmful because that is almost pure fruit sugar devoid of the fiber. Okay. Can you go to the previous one? Okay, go to the next slide. Okay. Sorry? You want it? You'll take it. So this is a meta-analysis which shows the intervention on this arm and no intervention to prevent gestational diabetes, physical activity and development of gestational diabetes. All these studies in the meta-analysis show that there is a definite benefit of introducing physical activity, exercises, and also dietary measures in patients who want to become pregnant and those who are at risk of diabetes. So, looking at this data, there are different quintiles of activity score. Increasing quintile means higher amount of physical activity, and that would show you the different metabolic activities, equivalent activities per hour per week, increasing activity, and here you can see the risk of developing cases per year, persons per year. So the number of cases per person per year starts decreasing from 300 down to 250, depending on the amount of increased physical activity that the woman does. So that is just to show the evidence base. So again, in a graphical pattern, if you look at the relative risk of developing gestational diabetes, and this is the total physical activity, metabolic equivalent hours per week. With increasing activity, the risk of, with the total physical activity, risk decreases. How vigorous is the activity? Vigorous physical activity helps even better. So more vigorous physical activity, more the duration, lesser the risk of gestational diabetes. Okay, so these are the relative risks, again in a different way. Casual exercise, normal exercise, walking, very brisk or very brisk exercise, and you can see again the relative risks dropping from 1 to 0.79 to 6. So that, and this is a clinically significant improvement. So there is definite evidence of improvement in the risk of gestational diabetes just by the activities. Go to the next one, please. Yeah, next one. Okay, so again this is the repetition of the previous slide, but more focus on the foods. Okay, so nutrients such as cholesterol, obviously it's very obvious. Increasing fat in your diet can increase the risk of gestational diabetes. Increasing animal protein increases the risk of gestational diabetes. Next one. So among the modifiable factors, what is recommended is at least exercise 30 minutes a day per day, and do not smoke. And aim for a pre-pregnancy body mass index of less than 25. That's for a Caucasian. For an Asian, I would say less than 23 body mass index. And a good healthy diet, food rich in vegetables, salads, and cutting down on the animal protein and not smoking. Nuts are supposed to help. Okay, next one. Okay, so having more protein in the diet is supposed to increase the risk of gestational diabetes. The mechanism is not well understood, but vegetable protein does help in reducing the risk of diabetes there. So how to prevent, again this is a summary of that. Smoking, avoiding smoking is always useful. Preconception, exposure to microwavable food additives that you should avoid. Improve the diet, improve activity and reduce sedentary behavior, which was seen in the previous studies. Prolonged TV watching is obviously dangerous because it increases the risk of diabetes. Next one. And this one's the second topic discussed in the ASD is it worth treating? I think I alluded to it briefly in the beginning. Is it gestational diabetes worth treating? So this was discussed in the recent ASD. Next slide. Okay. Again, this is the risk of short-term and long-term complications. As I said, short-term complication is pre-eclampsia, eclampsia, need for cesarean section, macrosomia, and maternal injuries because of problems during delivery. And long-term is for the baby. There is increased risk of diabetes in the baby and also in the mother. Anybody who has had gestational diabetes, there is about 50 to 55% chance that that woman will develop full-blown diabetes within 10 years of time if they are not careful. Next one. I think I'll go to the next slide. So this is a study where we looked at the primary clinical outcomes on the infants and their mothers in two groups of patients, where in one group there was intervention and in another group there was no specific intervention. So I don't think it will be acceptable ethical these days, but this was done some time back. So in the intervention group, the risk of any serious perinatal complication was 7 out of 500, whereas in the intervention which got only routine care, without the intensive intervention, 23 of them had complications. So there is, and this was statistically significant as well. So the complications they looked at is neonatal death, perinatal mortality, stillbirths, neonatal deaths, shoulder dystocia, bone fractures in the baby, nerve brachial plexus injuries in the baby, and the need for admission to the neonatal intensive care unit. So all these complications, and there is statistically significant benefit in managing gestational diabetes intensively. Next one. But what about the mother? You are doing all this for the benefit of the baby. Is it of any benefit for the mother? For mother, there is an inconvenience because you are managing the patient more intensively, which means she has to come to your clinic sometimes every week, sometimes every fortnight. So the number of interventions, number of appointments that you give for the patient is much higher. It's not just with the doctor, with the midwives, with the dietitians. So there are a number of appointments, and that is not possible for all the women to come to the clinic like that. Some are working until late in the pregnancy. So go back to the previous slide. So for the mother, there is the risk of cesarean section delivery, elective and emergency deliveries. So in this study, they couldn't find any statistical significance. The next one. And the secondary outcome for the baby. What is the weight of the baby after the intervention? So in the intervention group, 3.3 kilograms. In the non-intervention group, around 3.4. And this was statistically significant. Large for gestational baby, not really macrosomic, but almost getting there. So that also was statistically significant. Here in the intervention group, 68% of them did not had large gestational babies, whereas 115 out of the total 524 had large babies. So there is definite benefit in treatment. Macrosomia, numbers 49 here and 110. So you can reduce the risk of macrosomia, reduce the risk of gestational, large for gestational babies, and that will help reducing the risk of need for cesarean section. UPGAR score in the baby, much better. Low UPGAR score is much lower in the patients who had the intervention. Next one. So out of these two, the most important ones for you to remember is that macrosomia is reduced significantly in gestational diabetes if you have a thorough intervention right through the pregnancy. Next one. And for the women again, so I spoke to you about this earlier, number of antenatal clinic visits, so they actually increase totally. This is just for your clinics, and then the visits to dietitians, you can see here 400 visits to dietitian in this group, whereas the routine group had only 51 visits. So that means you increase the burden of clinic visits for the patient. Next one. Go to the next one straight away. And this is another study from Landon and others. Again, in this study, there are two groups, treatment group and control group, statistically significant. In the treatment group, the average weight was 3.3. In the other group, it was 3.4 kilograms. Birth weight, macrosomic babies were only 28 out of the 400.